Good afternoon, everyone. I'll be presenting a case of optic disc pit maculopathy that was initially diagnosed as central serous chorioretinopathy. So, serous macular detachments presents diagnostic challenge in clinical practice, while central serous chorioretinopathy remains the most common etiology. Atypical presentation requires systemic evaluation for alternative diagnosis. So, optic disc pit is a rare congenital cavitary anomaly of the optic nerve head. Prevalence is among 2 in 10,000, usually unilateral, but 15% may be bilateral, appear as a grayish depression, most commonly seen in the inforotemporal part of the disc. 25 to 75% cases of this optic disc pit develop maculopathy with serous macular detachment and retinochisis. Pathogenesis remains unclear. Fluid may arise from vitreous, subarachnoid space, or disc vasculature. So, 44-year-old male patient presented with painless gradual blurring of vision in the left eye persisting for 2 months. There was no history of any systemic illness, prior ocular trauma, ocular disease, or no medication or steroid use was there. Visual acuity in the left eye was 20/60 with no improvement with refraction. Pupillary response was normal and reactive. Anterior segment examination was unremarkable. And on fundoscopy, we can see an extensive serous macular detachment with the subretinal deposits. So initial fundus examination revealed classical features suggesting central serous chorioretinopathy, prompting further imaging studies. So OCT macula was advised, and we can see serous retinal detachment with disruption of photoreceptor layer integrity with increased central macular thickness. Then fundus fluorescent angiography was advised, and we found that there was absence of focal ink blot leak at the fovea, which was seen in typical CSCR pattern. There was no smokestack leakage present in the macular region, but a faint diffuse hyperfluorescence was noted in the peripapillary region. As there was no active focal leakage points identified at the macula, so these atypical angiographic findings prompted re-examination of the optic disc, leading to a detection of a subtle inferotemporal pit. So we advised OCT optic nerve head, and we can see the optic disc pit over here. So the findings, focal depression at the inferotemporal disc margin with hyporeflective cavity extending into the optic nerve head was noted, and there was a clear communication pathway between the optic disc pit and the subretinal or intraretinal fluid collections. So these findings definitely confirm the diagnosis of optic disc pit maculopathy, explaining the atypical presentation initially thought to be central serous chorioretinopathy. So the takeaway points from my case is that not all serous detachments are CSCR, and after seeing the subretinal fluid, we should not straight away jump to the diagnosis of CSCR, and we should always evaluate the optic disc carefully in unexplained maculopathy, and OCT optic nerve head imaging confirms subtle pits missed on the clinical examination. Timely diagnosis of the optic disc pit maculopathy enables appropriate referral and optimal management strategies.